Hello, Introduction to Human Services class. This is Professor McCartney. Hi. Excuse me. I'm going to talk to you about obsessive compulsive disorder. I'm going to give you an introduction, a little bit of an overview about this disorder. It is more prevalent than people realize, and the thing to understand is the difference between an obsession and compulsion, and how that's right in the name and what it means. It's a term that we throw around a lot, but it has a very specific meaning. I think some of the show Hoarders and some other things like that have made it more popular or aware in public culture or pop culture about the concept that some people might have something going on around obsessions and compulsions. So let's get more specific about that. An obsession is a persistent or recurrent thought, urge, or image that a person is experiencing, and it's intrusive and unwanted. It causes a lot of anxiety and distress in a person, and they can't stop these persistent thoughts. And the thought is like on a continuous loop, and it won't shut down. It varies from person to person as to what their persistent urge or image or thought is that is on this loop in their head, and it's really driving them kind of crazy. It is consuming all of their thinking, and they're not able to focus on other things once those thoughts are persisting and will not let go. And it could be something like somebody who checks on things, so they think that maybe they left the coffee pot on, but even though they've gone back and checked it, the thought keeps going through their head over and over again, unwanted. That may be that they have germs on their hands, and that thought keeps going through and through. So the obsession is about the thought or the urge or the image that is intrusive and unwanted. So the person is trying to ignore or suppress the thoughts or the urges or the images, and they're trying to neutralize them with that thought or the action. So the compulsion part of this is the behavior. It's the repetitive behavior, the hand washing, the checking on things, the mental acts of counting or praying, repeating words silently. And the compulsion is the action that the person is taking, trying to reduce their anxiety and their distress. So the compulsion, they're doing this in order to help themselves. So they're trying to feel less stressed and to stop that obsessive thinking and the obsessive behavior with the compulsion. So the compulsion comes in of, did I turn off the coffee pot? The compulsion, that's the obsession. And then the compulsion is to check it. So the person goes and checks it. Then they walk out of the room, and that intrusive, persistent thought comes back. Did I turn off the coffee pot? And they have to go back and check. They could go through that 15, 20, 30, 40. It could go on and on, the number of times, okay? So the behaviors or mental acts are aimed at preventing and reducing the anxiety and distress. Sometimes they work, sometimes they don't for the person. they are not connected in a realistic way, and they actually don't end up neutralizing and preventing. They are very, very excessive. And then this can manifest itself in young children as well as adults. And so a young child may not be able to articulate why they're doing this behavior. So obsessive compulsive disorder can come along with a genetic component. It can come along wrapped in something else around autism or some other things going on. With a young child, it can be tied in around an abusive environment, and they want to control their environment, and it's something that they get into as it's trying to soothe them. So it can come up at different ages in a person's life, and it varies in the intensity. So for some people, it might be mild. For others, it's extreme. It also varies depending on stress. So for some people, if they're in a very stressful situation, their OCD will kick in and become all-consuming. For some, maybe they're able to manage and it's at a more mild situation. Let's go to our next slide. Obsessions and compulsion, OCD, having the obsessions and the thoughts and then going through the compulsions, it's very time consuming. Excuse me. And this is part of diagnosing somebody through the DSM-5. So in order to rise to the level where a person would be diagnosed with OCD, the time consumption is actually part of the diagnosis. So it needs to be taking up more than an hour per day to be considered clinically diagnosed. So clinically significant distress or impairment in social, occupational, or other important areas of functioning. And so that's a key component of making a diagnosis and using the DSM-5 for OCD. So the obsessive compulsive symptoms are not attributable to the psychological effects of a substance. So here's a piece that some substances and medications can bring this on. And so it is important to rule out that the OCD was not caused by a particular medication or a drug that the person is abusing. So that's an important part of diagnosing. The other piece of diagnosing is ruling out other ways that there are other types of diagnoses that can look very much like OCD. It's not, if the OCD is not better explained by the symptoms of another mental disorder. So it can, that might be like body dysmorphic disorder is something that comes with a severe PTSD. Hoarding disorder is very related to OCD. They are siblings, but the hoarding then is considered its own diagnosis. While they're the same family, they are not exactly the same disorder. But understanding one helps you understand the other, if that makes any sense. Substance abuse and addictive disorders are very much related as well. It's that similar type of pattern where the person is obsessing about the substance, and then the compulsion is to take it and to have it. But the origin of it has to do with the pleasure center in the brain that the substance is controlling. So the origin comes from a different place. So schizophrenia also has some complications that look like OCD. So these are some things that you would rule out. And they may be their own disorders, but have behaviors that are very much look like and feel like OCD. So I've included in the some resources for you to look at further information about OCD, and that's in the PowerPoint that's been shared with this clip to learn about. So it's an article that's more comprehensive about obsessive compulsive disorder diagnosis and management, and it's going to give you some more specific examples of things. So an example of symptoms of patients with obsessive compulsive disorder. One might be contamination. So unfortunately, a side effect of COVID-19 is that if anyone has a leaning towards, or maybe a mild case of OCD that they were able to really be managing, because many people do, and honestly, they're also the best employees. I had a secretary one time with OCD. I have to tell you, she's the best secretary I've ever had in my life. If you want things organized and to know exactly where everything is, absolutely, there's some side parts to this that can be highly effective if somebody is in a situation where they are managing and controlling the OCD in an effective way, and it's mild. But if, say, a person is managing and, they have a mild situation going on of OCD that's not risen to the clinical level of diagnosing where it's consuming much of their day, it could be kicked in to the situation where it becomes clinical and becomes much more severe under duress. So let's think along the terms of, at the moment, what's going on with COVID-19, and read this. Contamination is an obsession. Examples: fear of being contaminated or contaminating others, fear of being contaminated by germs, infections, or environmental factors, fear of being contaminated by bad or immoral persons, associated compulsive behaviors, washing or cleaning rituals. The entire world right now is being asked to fear contamination. And it is on every news cycle. It is every time you turn on any phone, radio, or TV, and it is telling you to be absolutely fearful of contamination, of germs, and to wash your hands, cover your mouth, etc., etc., etc. If you don't think that people who struggle with a mild situation of OCD, or those who've never even experienced it before, are now suddenly in a severe situation of being consumed with OCD, yes, think again. Think about this. So this is an example of something where the realities of our present world have a direct and negative impact on a mental disorder that I'm sure is causing an extreme challenge for many, many people. Okay, so there's other ways that there are obsessions. It could be around self-control. It could be around sexual thoughts, superstitions, fears, certain bad numbers and colors. Um, so some people, their compulsions have to do with counting, ordering and arranging. Um, Sometimes it's washing and cleaning. Sometimes it's praying and asking for forgiveness. So now the good news is that it's very, very treatable. So one of the things to look at is that cognitive behavioral therapy, exposure and response prevention is excellent for treatment. And there's also a lot of medications that are very helpful. And so that's something to know about. So any of the serotonin reuptake inhibitors are a specific class of medication that deal with serotonin, which is a chemical in your brain that regulates mood. And it's a common medication that helps with depression and anxiety. And it also can help alleviate obsessive compulsive disorder. So a mix of cognitive behavioral therapy and medication can be very effective in helping with the treatment. That article is available for you to read with the PowerPoint. And then there's a book that I really, really like. It is old. It is by a woman who was the pioneer for this this disorder, and she's a brilliant psychiatrist, Judith Rappaport, and it's called The Boy Who Couldn't Stop Washing. And it's had many versions of it. You could probably easily get hold of it for free. The link I have here is for buying. I'm not meaning for you all to buy it. I just want you to know about the book. There's a lot of resources available online right now called, for example, Libby is a way that you can rent books for free from a national library source. You could also listen to it and an audio version of it and download it. Since it is an old book, you could easily listen. The thing I really, really like about it is that it's actually written by first-hand accounts of people that she worked with. And as she was learning about it, she was able to get people to trust her and to really get in their head and have them write exactly what it was feeling like. And I found this book to be incredibly insightful and helpful, and I have never forgotten it. And I've probably read it about 20 years ago. In terms of having the gift of hearing from people firsthand or reading from people firsthand as to what it feels like when they are living with OCD. And so I think that is really valuable as you work with people, that you have that understanding and compassion about how consuming this can be. So some key points to pay attention to as you might move forward in the world working with people. Listen carefully to clients and pay attention. This is very underdiagnosed. And people are secretive about their behaviors. A lot of times there's a lot of shame that goes along with OCD. I wish there wasn't, but there is. And people don't open up or talk about why this is happening to them. They don't understand it. They would like to be able to control it, and they're not able to control it on their own. And the first response is to hide it. So people live with it for many years before it gets bad enough in their mind, although it's probably was bad enough years before they actually ask for help. And in the meantime, they have shut down many opportunities in their life, whether that's around leaving the house, employment, relationships. They've lost a lot by not getting treatment. And so listening to people for signs that maybe they're not fully articulating and you only catch part of it, or you observe. Sometimes you'll see little ticks. You'll see people like there's something that's misplaced in your office and they'll put it back. I've watched children come into my office and they start changing and rearranging all the toys and color coding them. I just stepped back and let it happen, and I just watched just to see how long this went on, what happened for the child. And then when they seemed to be done, I asked them to just talk to me about what was going on in their head and what they were thinking about. Sometimes I've watched people walk along and I realize they're counting under their breath. Or they just counted the stairs, or they suddenly had to say something when they got to the stair 3 and then at stair 6. Or I've watched people count tiles as they go along. Pay attention. That's where you're going to see the signs more than somebody sitting down and saying, oh, I think I have OCD. Okay? It is the extent to which this intrusive behavior monopolizes the person and consumes their time. That's a really key point here. So someone may say, oh yeah, it's just something I have to do, but then when I leave the house, I'm fine. Okay, so that might be a discussion of what do you know, and just making sure that the person has education about OCD, that they know there are treatments, there's medication. And one of the huge questions I ask all the time with people, not just with obsessive compulsive disorder, with any disorder that I'm worried about, I say, how much is this keeping you from doing things you want to do? That's the question you have to ask yourself. I say, does it stop you from doing something you would like to do? Does it stop you from applying for a new job? Does it stop you from getting to your friend's birthday party? What does it stop you from doing that is interrupting your life? And at what point do you feel you need treatment? And I'll ask folks, and again, this is for any disorder, not just OCD. I'll say, what's your breaking point? What's for you? You may not have an answer for me for this question right now. I just want you to think about it. What is the point where you will say, enough? I don't want to live this way. It's getting in my way of living, and I would like to have more control and management of it. Right? I feel like an invisible line has been crossed, and this disorder, this problem, however you want to name it, is controlling me rather than I'm controlling it. And so for each person, that's a different point where they say enough is enough. But I ask people to personally, internally think about what their point is to make a decision for themselves. So, OCD unchecked can shut a person down from functioning. This is something to really realize. It can be kind of invisible and insidious, and um, the person can start disappearing, from showing up on time, from not, oh, I'm sorry, yeah, I was going to come to that, I really wanted to come, but I couldn't make it. Kind of excuses and things happening, and not a lot of explanation about why they missed an event or why they weren't able to be there. um, and and embarrassment goes with that. And so people just um, stop stop being able to have a job, stop being able to have friends. So it becomes all time consuming. People can wash their hands to the point of bleeding. They can be counting so much that they're not able to have a reasonable conversation. Okay, we've talked a little bit about number 4, which is that OCD is very treatable. It responds well to medication and cognitive behavioral treatment. There are multiple programs, and there's really well-researched treatment programs. So it is something that can be managed, and managed quite well. OCD can stand alone, or it can be comorbid, so meaning it is in combination with other disorders. So it does have a pretty high comorbidity rate, because of there are some other situations that people get into where their thoughts are getting obsessive, and then they are needing a behavior to reduce that anxiety, that compulsion. Autism, the autism spectrum disorders. OCD is part of and often found with autism. So it is frequently part of the autistic spectrum disorder. People with autism, the way their brain is functions is that it gets stuck in one part of the brain rather than going through a central channel that most of us have, which is our social center in our brain. And it's literally in the center of the brain, and it's like a rotary where you connect ideas and they kind of spin out to other sections and you make connections. When you have that feeling and you go, oh, okay, I can connect this to that to that. Okay, that's a typical brain. A brain of a person with autism, they get stuck in one quadrant and stay there, and it's really hard to shift them. So they might get stuck on math, on a math problem, and they'll think about that same math problem for hours. Now, brilliant part of that is they solve some incredible things and do and create, amazing things in our world because they're able to stay stuck in that one spot in their brain, to work on that one problem. Now, even in the description of that, you can hear how that really becomes obsessive. So you just often, it is very paired with autism, and people do get stuck. And if you've ever worked with somebody with autism or have a friend or a relative or whatnot, you know that once they are stuck on a topic, it's really hard to get them off of it. So the piece where it would become OCD is when there's a compulsion that has to go with it. So, having to count to soothe, or needing to have one of those compulsive behaviors going along with it, which you can frequently find. So I hope that this helps you a little bit in understanding a little more about obsessive compulsive disorder. And please go ahead and read the article that is attached, or think about, listening on tape while you cook or work out or whatever to the Judith Rappaport book, if you're interested in learning more about this topic. Okay, be well.